Absolutely. So this is healthinsurance.org, Curbside Consult. This is Harold Pollack talking to John Gruber. By the way, I'll give another mea culpa, which is I got called by PolitiFact about Florida, and Governor Christ said that they're killing 6 people a day by not by not expanding Medicaid, and I sort of looked at the data and I said, well, that's probably on the high end of a speculative estimate, and PolitiFact sort of gave him a half true for that. And what I really should have said is they're actually probably only killing 3 people a day. And I blew the opportunity to clarify, because that's actually what it turns out. If you run the numbers, that's sort of closer to what he should have said.
Right.
But it is amazing. Let me ask you a couple things about the substance of the law. So now that we've sort of seen it in operation, there's this whole political fight going on that we've been talking about. Are we seeing some things that we should be changing in the way the law was written or the way it's operating? That should we have an opportunity to make some legislative fixes that we might want to go do?
Let's separate the substance from the politics. Substantively, I don't think we know enough yet that we should change anything. I don't see. I mean, there are things I would change that I would have changed a year ago. For example, I think that the cost-sharing protections for people in the sort of, not the poorest people, sort of people in the low income, 150 to 300% of poverty, they're going to face some pretty high costs relative to their income. Mm-hmm. That's something I wrote about a couple years ago in a brief for the Commonwealth Fund. So that I'd fix. But there's really nothing we've learned in the past 6 months of substance that should impact the law. We've learned a lot of political problems we didn't do a good enough job anticipating. But I don't think we learned anything of substance that's wrong with the law in the last 6 months.
Are there some political problems that we haven't talked about that we should just mention?
Well, I think the big thing is, the employer mandate. The employer mandate, represents, I don't know, something like 1/10 of the revenue of this law, mm-hmm. but it represents maybe 3% of the benefits in terms of covering people, but it's causing maybe 90% of the political headaches.
Yeah.
So you got to seriously ask yourself if that's worth the political cost. If you got rid of the employer mandate, you'd have fewer than 1 million more uninsured people. Now, that's a lot of people. That's a shame. Mm-hmm. You'd lose a lot of money, so you'd have to make that up. But, boy, that would get rid of a lot of political problems. So I think it's something that politicians have to think seriously about, because I think it's just not clear it's worth the political headaches it's getting.
By the way, do you think that Democrats are going to start running on defending the ACA between now and the midterm elections, given that it's going a little better?
I think selectively. It's just the thing about the ACA that's probably the number one thing, and we'll see this politically too, it's just the heterogeneity across states. It's going so differently in different states. It's perceived differently in different states. I think, I could see California people running on it. Mm-hmm. I can't imagine Louisiana people running on it.
Or Kentucky, ironically, even though it's such a big success there.
Yeah. So, that's right. So I think that there'll be just a lot of heterogeneity around the country.
One thing I wanted to ask about states like Kentucky that are implementing the Medicaid expansion, they've reduced the number of uninsured by something like 42% in the state, which is amazing. Also, Medicaid is effectively becoming the 900-pound gorilla in the health insurance market in Kentucky. Something like 1/3 of the non-elderly population is going to be covered by Medicaid or related programs. How do you think that's going to change the nature of Medicaid as it takes on such a large swathe of the population?
Well, I think that's a great question, and I think the big issue is going to be, can Medicaid continue to pay its doctors so poorly as it's covering a larger and larger share of the population? I mean, part of the reason Medicaid is cheap is because it pays doctors so poorly. Mm-hmm. Can that continue when it's covering 1/3 of the population? I'm not entirely sure that's possible. So I think there's going to be some real dynamics. There's actually some good research that suggests if you pay doctors more into Medicaid, it improves health outcomes. So it wouldn't be the end of the world if we paid Medicaid doctors a bit more, especially for primary care and obstetrics.
By the way, one of the things that drives me crazy is Republicans have discovered that people on Medicaid can't always get the doctors that they want to see, and that Medicaid isn't a perfect program And, as someone who's taken care of someone on Medicaid for almost 10 years now, I sort of feel like women do when they're being mansplained to about, when a man is explaining menstrual cramps or something like that. When it's like, you mean that I can't, sometimes people are rude to me when I call up and I say I have a Medicaid patient who needs an appointment. But what's striking is that all of the critiques that Paul Ryan and others are making of Medicaid, when you look at their actual policy proposals, every one of them would make those features of Medicaid worse. If we block granted Medicaid, that's the single worst thing we could do in terms of encouraging states to raise provider rates and dealing with these other problems that are essentially related to the incentive to underfund aspects of Medicaid or to try to underpay for things.
I think the fundamental challenge, Harold, that liberals face politically is explain to the American voter the cost of those types of policies. I think the average American voter is actually a charitable person, a big-hearted person. I don't think it's that the voters in Florida don't care about the low-income uninsured. I think they're just misinformed. And I really believe that if we could politically help explain the cost to society of cutting provider rates, of cutting back Medicaid, I think we get the majority of people to support strengthening that program. I think it's just because of racial reasons and other things, we just haven't managed to get through with that message.
This is healthinsurance.org, Curbside Consult. This is Harold Pollack talking with John Gruber. I should, by the way, just to close this part of the conversation off, so we have this primary care provider challenge, and it certainly existed basically independent of ACA, but it's going to be aggravated as we bring in more people into the system. What are some things that we can do in policy to try to lessen the shortage of primary care options for people?
Yeah, I think, first of all, let me emphasize the point you made, because that people say, oh, we're going to have this primary care crisis because of the ACA. Well, that's not true. I mean, I think the facts in Massachusetts perfectly summarize it, which is the average waiting time for a family doctor went from 47 days to 51 days. Now, because of our healthcare reform, there's two ways you can look at that. One, you could say, wow, 4 days, that's a big increase. The other, you could say 47 days, that's outrageous. And that sort of summarizes the point that, yes, it'll get a bit worse, but it's already a problem. By the way, that's my bird you're hearing in the back with the whistle. If you're in the whistling and cheeping, that's the bird.
This is where you tell me your bird is named John Maynard Keynes or something like that.
No, Jomo.
Jomo, okay.
So, what can we do about it? I actually think there's really sort of fundamentally two things. The longer run issue is to change the relative reimbursement of primary care and specialty care in the U.S. That basically primary care docs are underpaid, specialists are overpaid. And that needs to be addressed. And I think as we move away from a fee-for-service system towards a value-based system, I think that will be addressed. In the near term, I think the real focus should be on scope of practice and expanding the scope of practice of non-physicians to provide primary care. Pharmacists, physician assistants, registered nurses. There's still doctors in America taking blood pressure. And there's doctors in America entering data. There's doctors in America doing things you don't need a doctor's degree to do. And I think that basically we need to really be sort of de-skilling the delivery of medical care and sort of getting all the stuff that doctors don't need to do out of their hands so they can spend more time actually seeing patients.
By the way, I would add the dental profession to that as well. And one of the most disappointing aspects of ACA to me is the failure to address dental care, which was just kind of literally a bridge too far. Dentists really have not wanted to treat the Medicaid population, but they also have resisted efforts to have other types of professionals treat the Medicaid population at the same time. And it's just every severely poor person basically that I've ever met, if they just open their mouth, you see their teeth have fallen out. And,
right.
And dental hygienists could, there's any number of things we could do that would in a cost-effective way provide basic dental care to people.
I totally agree.
But the political economy of the dental profession, as in the medical profession, makes that
hard.
That very hard. And one of the interesting things about health reform is that there's this ideological battle, and then there's these series of interest group politics battles and there's a big incentive for the various interest groups to glom onto the ideological cleavages as a way to avoid confronting changes that need to be made. So if you start debating, competitive bidding for wheelchairs and Medicare, there's a big incentive for the various interest groups to somehow try to tie that to the liberal-conservative fight over the rest of ACA, and it really is a totally independent issue.
Right.
And I suspect that George W. Bush's Medicare people and Obama's Medicare people have much more in common with each other than either one would with a congressional committee chair.
Yes, I agree.